She's going to speak about menopause and its relevance in our physiotherapy. And in this context, I would like to thank our management and also our chairman, M.N. Raju sir, and vice chairman Ravi Varma garu, and also our dynamic principal Madhavi ma'am for making this happen. It's the 8th international webinar we are conducting, and I'm very much proudly saying this, that we have done this with the help of our dynamic principal, with the help of our dynamic principal only. This wouldn't be possible if ma'am wasn't there. Yeah, and another important point here. For this webinar, this particular webinar is being streamed live on YouTube, Facebook, as well as on Physiotv. So technical support is being given by our Physiotv group, especially Mr. Rahul Chaube. I would like to thank him for making this to happen. Yes, now I would like to ask our principal ma'am to speak few words about our guest speaker. Ma'am, you can speak, ma'am.
Able to hear?
Yes, ma'am.
Yeah, but yeah, 1 second, please. Okay, fine. Thank you for that nice introduction, Rameshwar. So once again, namaste and good morning to everyone present here today. And I take the honor of welcoming you all on behalf of MNR Sanjeevani College of Physiotherapy, MNR Educational Trust, to our 8th webinar. So I'm K. Madhavi, principal of the college, and today's topic is physiotherapy, an efficient tool in the management of menopause and post-menopausal symptoms. Women past certain age will experience menopause. It can cause many changes in the body, and they experience a variety of symptoms, right from weight gain to osteoporosis. As a physiotherapist, how best you can change the lives of these women? So let us all pay attention and listen to today's topic. It's a great pleasure for me to introduce our speaker today. Am I audible?
Yes, ma'am, you're audible, ma'am.
I'm audible, right?
Yes, ma'am.
So, yeah. So it's a great pleasure. I mean, the speaker, Dr. Anu, you're not able to listen? I think, fine. So let me continue with this. Dr. Anuradha Pormala, a BPT graduate of 1998 batch from SWIMS University, Tirupati. She moved to Canada in 2015 and started her career as a registered physiotherapist. And she deals with outpatients in Calgary at multidisciplinary clinic, and she has a vast experience in treating women's conditions, especially menopause and postmenopausal symptoms. She's a woman of great expertise, whom I know personally as a very good friend for the past 20 years. She's one of my friends in BPT. And I thank you for joining us today, for delivering your valuable speech. And I also thank our management, our chairman, Sir Shri M.N. Raju Garu, and vice chairman, Shri Ravi Varma Garu, in opportunity in conducting these events such as webinars. And I thank the whole team of Sanjeevani College of Physiotherapy for their relentless work throughout. I thank Mr. Rameshwar today, and also thank technical support team here, Dr. Ashok, Mr. Rahul, who are making this webinar on a platform that is Physiotv, and on YouTube channel OrthoTV. Thank you, one and all, and over to Rameshwar.
Thank you, ma'am. Now I would like to ask ma'am to speak few words. Just a minute. Yes, now I would like to ask Dr. Anuradha ma'am to make Anuradha ma'am as the host now, and can you hear me, ma'am? Ma'am, can you hear me?
बटले तो रुपये तुक्का बट उसको था जल्दी आलू नहीं होना निकाल दो
A small request for
नहीं
everyone.
तुम निकालो मागू नहीं होना ना
Please keep your devices in mute, please. Ma'am, Anuradha ma'am, can you hear me, ma'am?
Yeah, Anuradha ma'am is for her it's not audible. It seems. Just a second. She's just connecting the earphones. Maybe the issue will be solved in some time. Please wait.
Okay, ma'am. Anuradha ma'am, you can switch over to call over internet button, ma'am. Switch on that call over internet button, and then you can connect to the audio, ma'am. Ma'am, Anuradha ma'am, you are the host now.
Hello, Dr. Anu. Hello, Dr. Anuradha. Unmute.
Ask him to unmute it. So I just started with the. No, I just started with the laptop. Okay, so okay. Is it audible now?
Yeah.
Yeah.
You can just take this out.
It's okay.
So how?
It's okay.
Yes. Hello.
Ma'am, you are audible, ma'am.
Yeah, thank you. I'll be there.
Yeah.
Okay. It's all fine now?
Yes, ma'am, it's fine.
Okay. Thank you, Madhavi, for the introduction. And I thank Patron Sir, Chief Patron Sir, Convener Dr. K. Madhavi, organizing member Rameshwar, for helping me to have this session, webinar session. Thank you very much. So today the topic is, it's a very simple topic, and I just want to ignite the young minds that in the field of women's health and in this field of, especially in the pelvic floor, we have a role to play. And in easing the symptoms of menopause and post-menopause, I want to enlighten you that there is a great role of physiotherapy. So maybe I'll be touching a lot of things in brief, and maybe some I'll try to explain the things. And anyhow, I'm not sharing the screen as all the stuff I may be discussing. Maybe it's easily available at just a mouse click away for you in all the websites and all the things. But we'll be carrying out this session in such a way that it's really helpful for you, young minds, and it may pave you a way in the future that you establish your passion in this specific field of the women's health, and in specific, the pelvic floor physiotherapy. So in a broad and all, this is a super specialization, the pelvic floor physiotherapy. And in all the terms, there is a lot of demand as well as a lot of scope for advancements, progression, and research as such. So everything is fine, Rameshwar. I can go forward, right?
Okay. Everything is fine.
Okay, thank you, sir. Coming to my topic, if I jump into my topic, so menopause, post-menopause, and I mean to say there is physiotherapy has an efficient tool in the management of symptoms of menopause and post-menopause. Anyhow, we are there for better functional outcomes only, okay? And a brief definition about menopause. It occurs when there is complete or near complete ovarian follicular depletion and loss of ovarian follicular activity, which is resulting in permanent cessation, that is stoppage of menstrual cycle. So in brief, the medical terminology, it means like there is complete ovarian follicular activities depletion or stoppage, which leads to the absence of the menstrual periods. And we are concerned about this period of perimenopause too, because peri always refers to the time around. The symptoms of menopause, when the levels of estrogen, they start depleting along with the progesterone. So women, they start experiencing the symptoms of menopause. Some have great wide variety of symptoms in the perimenopause. And when they enter into menopause, most of them, they subside or they get better too. So we need to know about the perimenopausal symptoms, which are more or less of the menopause and the postmenopause only, because it's a transition period, okay? Coming to the symptoms. So as such, there are 34 to 36 symptoms of menopause. The first one is known as the hot flashes. You might be knowing like it's the creeping feel of intense warmth. It's a feeling of warmth that quickly spreads across the whole body, which is mostly felt in the chest region and in the face region too. Sometimes when this creeping sensation is more, when the hot flashes are in intense manner, it may even cause sweating. And if it is sweating is for a profound time, and it can even cause the palpitation too. So we'll deal later in depth regarding the explanation and how to deal some of the symptoms. So this is one of the symptoms we are dealing with. Next one is the mood swings, headaches. So as estrogen is getting depleted or getting the volumes of estrogen which has to be secreted or getting decreased day by day, it also causes in vaginal dryness. In the breast, again, it's related to all the hormones. So the breast soreness, and our favorite part and where we have an intervention is the joint pain. The related one, the muscle tension, electric shocks, more or less related to the hot flashes. So other age for the menopause is around 50 years in the Asian or Caucasian population too. So, the aging factor, the hormonal depletion, if the women has any of the other existing medical conditions, so there are chances of even the nerves are being affected or circulatory compromise is there, and it can lead to the tingling extremities too. That is in the hands and the feet, they feel an intense tingling sensation. Okay, so Other factors like whenever the boost up of hormones is less, so it leads to fatigue, disease spells, weight gain. Weight gain is a vast one, right? So a lot of factors have to be taken into consideration when it comes to weight gain. We'll deal in the as we go through this webinar. So the urogenital system. This is one which is mostly affected because the hormonal part that is acting, so it results in any of the incontinence, stress incontinence, or it can be like urge incontinence. And so we'll deal with this also how while we are dealing with the management part of the management part of menopause. Next comes osteoporosis. Another favorite part for the physiotherapy, well versed. Maybe you guys know more than me about this. And let's see, and I will enlighten whatever I know and whatever the time permits too. So all the changes are taking place in the women's life at the time of menopause. Like there are hormonal changes, age factor is adding up, or the life stresses are there. So definitely it may lead to weight gain is there, and a lot of lifestyle modifications maybe at this age are happening. So everything together, it put together may cause like depression, panic disorder, anxiety in the women. These are the associated conditions which are seen in menopause. We need to know a little bit about them, okay? Because we are always dealing with the comprehensive management of any of the condition in physiotherapy. It's not a single man's approach. So whatever, we work in a team. So we need to know about the medical aspects of the condition. We need to know about the psychosociological aspects, little bit about the radiological part and the rehabilitation part. So directly we are associated with the physiatrist, the social worker and all. So we need to know the roles of other ones so that we can cook a very good combo, okay? So coming for the types of menopause, usually as I mentioned, 50 years or 51 is the average period for the woman to enter into menopause. But there are certain factors like whenever there are premature factors which are contributing premature menopause is there when there are certain factors like smoking, radiation exposure, and chemotherapeutic drugs. So if these are there, that may lead to sometimes the premature menopause, like women may enter into menopause before the age of 40 years. So another one which is commonly you guys may be seeing is surgical menopause. It's self-explanatory. That is, whenever there is removal of ovaries or whenever there is some intervention with the uterus and the ovaries are attached or removed, that's it. It may lead to the cessation of the cycle, which we call as surgical menopause. So as I told you, there are a lot of effects of menopause, physical effects, psychological effects, social effects too. That's just for your information. So our concern for today is joint pain. Or we will go to the broad terms. It can be arthritis. So in broad sense, any of the musculoskeletal pain can be there. So whenever there is musculoskeletal pain, again, you have to take into consideration because the age of the client who entered into menopause may be 50 years. So what are the other, any of the lifestyle factors are there which are contributing to the musculoskeletal pain? Pre-existing medical condition is there which contributed to the pain along with the menopausal changes and menopausal effects on the joints or on the leg joints and all the skeletal structures which are leading to the musculoskeletal pain. So always it's advisable to have an individualized screening techniques, individualized assessment skills to know what are the causative factors, etiology for the musculoskeletal pain. So if it is only the hormonal part which is bugging you, which is causing the pain, then you have to go as it's clearly explains that from the medical point of view, hormonal replacement therapy. And as you work in I said, in a multidisciplinary team, you should always be having a knowledge whether any calcium and vitamin D supplementation is being given. And coming to our part, so exercise one. Low impact exercises. It can be swimming, yoga, biking, Zumba, according to whatever is convenient to the patient and whatever the patient is used to maybe in the past of doing the exercises. So you can have an exercise program on that one. So bone health. So you have to educate the patient regarding the bone health, and you have to give a exercise prescription. So I wanted to specify the word prescription, because exercise is not just doing any sort of moving of the joints in whatever fashion is that, because everything has a physiology and also the science behind that, how the exercise is working. So maybe you need to concentrate on, while giving any of the exercise, the aerobic exercise, or you're giving any of the strengthening exercise, on the FIT principle, which is frequency, intensity, time, and the type of exercise. So if you're giving this prescription to the patient, depending upon the assessment and the results you're getting from the patient, and depending upon what are the treatment protocols you set up, what are the short-term, the long-term protocols you're setting up for the patient. So that gives you very best results. Because, if you go through the exercise therapy part, you may feel that it's very easy part and more or less everything will be the same with little modifications. So you have to pinpoint and be very specific how to work out an exercise for an individual client. So that's what I want to stress, because the rest of the part, I think you know how to give the simple exercise for the musculoskeletal concerns or arthritis or joint pain. Okay. The other part, osteoporosis. So bone mineral density, it decreases, estrogen is coming down, if aging process is taking place, any other existing medical conditions, all predisposed to osteoporosis. They are the factors which add up to that. So it is commonly seen in postmenopausal women. The concern is again the estrogen progesterone part. T-score, you all know there are diagnostic scores like -1, -2.5, osteoporosis, and less more than -2.5. I think it's osteopenia. So according to that, you have to take care how well you are going for the exercise protocol. So because safety of the patient is also very, very important. Whenever you are giving exercise in osteoporosis, you should not land patient in a different problem, right? So that's how we have to go through the things. So you all know vertebral fractures. They're commonly seen when a woman is osteoporotic. So you have to take, again, the history part, assessment part is very important. But the previous history of fractures, how well other factors are being established, and the lifestyle which the woman is having, and all the predisposing factors for the osteoporosis, and you have to address each one of them. Coming for the exercises of the osteoporosis. Concentrate on weight-bearing exercises, strengthening exercises, postural exercises, and balance exercises. So these are the exercise part. Depending upon the need of the client, you need to design the exercise program for the client. Okay. And in osteoporosis, avoid the flexions and go for the extension, like chin tucks, scapular squeezes, hip extension, and all go for the extension, because we don't want to do anterior compressive forces, and we don't want to push the patient towards more fracture already when the bone is very weak and not able to bear a lot of forces. Okay. Next is, whenever we are planning for the resistance exercises, our aim will be, you want to load your muscle. So you want to increase the muscular loading. And whenever, as in osteoporosis, you are going for the weight-bearing exercises, it's the mechanical loading you are concentrating on. So whatever the exercise prescription, either resistance or weight-bearing, the efficacy is here. You want to decrease osteoclastic activity, increase the bone building cells, that is osteoblastic activity. So depending upon that, there are a lot of exercises in osteoporosis. If you go through standard books, websites, they give biking, Zumba, weight training, swimming, yoga, and exercises in different positions like squatting position, sit to stand position, step up positions, and a lot of positions according to whatever is favorable to the patient. The patient is too heavy and the patient is not able to have a one derived position, you can do the exercises in any of the positions, but have the safety of the patient as the main concern, and whatever you are having the plans for the patient, go to that. Okay. Next is, so even the heart is affected because of low estrogen and this progesterone. So go for the regular gradual aerobic training, cardiac conditioning exercises. So again, whenever it comes to the cardiac conditioning exercises, you have to take into consideration heart rate, pulse rate, other factors, any of the existing heart conditions and all. And you can go ahead with the cardiac, this conditioning exercises. It should be a graduated exercise, which helps and which has more results in the patient. So that cardiac conditioning part, it's as simple, and I think you all guys know how to go forward with that. Aquatic exercises. So allows for the reduction of stress on the muscles and the joints. So it's maybe the priority to be given, so that in the initial stage, the patient has ease and more flexibility in doing the exercises. As you know, the properties of water like buoyancy, viscosity, they all help the patient and aid him to get into the routine of doing the exercises and have the ease while doing the exercises. And gradually you can increase the resistance and the weight bearing according to your whatever your progression your client is making and the requirement of the client, the patient. Okay. Coming for the incontinence part, which is seen due to the depletion of the estrogen and the progesterone. Usually there are two types, that is the stress incontinence and the urge incontinence. The stress incontinence, it comes into play whenever there are any of the physical stresses, like even forceful coughing, sneezing, or if you're carrying any weights or a strenuous activity. So there will be like incontinence, an episode of incontinence whenever you're doing this stress, physical strenuous activity. So that comes under the stress incontinence. Next is urge incontinence. Urge incontinence is very debilitating, as the client will not be able to even go make himself to the bathroom. Before that, they may have the incontinence, urinary incontinence, because there will be an urge to pass the urine. So this type of both the incontinences from the physiotherapy point of view. So there are a lot of tools in our toolbox which we can work out. Like the basic one we are dealing with is the pelvic floor training that you are doing. So whenever it's the pelvic floor training, there are a lot of things again, like the Kegel exercises you can use. You can use the vaginal cones, vaginal weights, and a lot of other things like now modern things which are helpful for the patient to have a sense of knowing what's going on, what we call in our medical terms, that is the biofeedback. So you can have a lot of this gadgets, equipment are there. We'll be dealing in my next slides. And it's always from the patient point of view to have a better history from the patient. You can ask the patient to maintain a bladder diary. It's very simple one, so which may have that how much intake the patient is taking. That means the fluid intake, or he can be any juice, at what time he's taking, and how much intake he's taking. And if at all he's going for the urination, whether it is an urge to urinate or it's a normal way he's passing the urine, and how many times he had an urge in a day to pass the urine. And regarding the output, how much output he's getting, if at all he's able to maintain the measurements, like how much ml he's getting. Out of that, you can know the episodes, how frequent they are, and you can work out according to that. So it's a scientific and more logical way of approaching for the urinary incontinence. So whenever you are dealing with a pelvic floor problem, it's a concomitant of a lot of things which are going on. So if it comes to physical examination, it's always ideal to have the examination of the back, the pelvis, sacrum, pelvic floor muscles, and the nerve function. So that's why I was telling you right from the beginning, it's a multidisciplinary approach. So whenever the urogenital specialist, urologist, he has sorted out that no abnormal pathology is going on and the physical therapy intervention is okay to carry out, then comes into play your physical therapy. So you can just start with intervention, like very simple things which we use in the normal clinical things everywhere in physiotherapy clinics. Like you can first start the patient with the electrical stimulation, and you can notice is getting better, she's getting better, and according to that you can go for the Kegels exercises. Whenever the Kegels exercises point is coming, first you have to let the patient know how to identify the right pelvic floor muscles. So whenever it comes to the identification of the right pelvic floor muscles, so you have to teach the patient, first give a relaxed position and take a history from the patient, what's happening regarding the incontinence, and coming for the identification of the Kegels. The pelvic floor muscles. So whenever it comes to identification, then you can ask the patient, do a simple thing like, whenever the patient is trying to stop the passage of gas, the squeeze he's taking the squeeze he's making at the rectum, the same squeeze if he's able to make and stop the passage of gas, that means he's at the pelvic floor muscles. And other one is whenever you can tell the patient that if he's in a social place, public place, and not able to urinate. So the squeeze he's doing to hold the midstream of urine, ideally, that squeeze, when he's able to do, that means he's using the pelvic floor muscles. So you may be knowing the pelvic floor muscles. I may not name ilio, that is coccygeus, pubococcygeus, and the levator ani, and the urogenital diaphragm and all that. So that and the part, that's, I think you all know. Okay. So whenever the squeezing, the right squeeze of that is taking place, you are at the pelvic floor muscles. And when the progression of identifying the pelvic floor muscles is there, you can ask the client to do the things, both the things together, stopping of gas, holding the midstream of urine. Then you can even stimulate the deep layers of the pelvic floor muscles. Once the patient is at right identifying the pelvic floor muscles, you can shoot her with the Kegels exercises. So the Kegels exercises, or a set of exercises which are designed to strengthen the pelvic floor muscles. As such, they are very simple, but they should be done in a righteous manner, or a very right way. That's the only thing. So the same thing you're telling to the patient in doing the exercise, that is, stop the midstream of urine, hold for a contraction of 2 to 3 seconds, and then releases. So to start with, the frequency will be 5 sets, 10 repetitions per day, which is more ideal. Okay, like that you have to go ahead with dealing with the pelvic floor problems. So if you just want to do some simple test in your physiotherapy clinic, you can go ahead with the pad test. That is a pre-weighted pad, can be given to the client. You can ask her to use it. And then while the pad is in, you can ask the patient to have 500 ml of sodium-free drink in less than 15 minutes. And you can ask her to do some sitting, resting, walking for 30 minutes, doing sitting to stand, like 10 counts, coughing vigorously 10 times, running on the spot. So you're just inducing and increasing the stress on the pelvic floor and seeing how many leaks are taking place and how much urine is leaked during this process. Okay, so you're provocating a kind of bending to pick up the object from the floor. These are all the things you can do in a 1 hour period. So because we evaluate for a 1 hour period when the pad is on. Okay, washing hands, running. Yeah, so you can carry on this one, and you can measure the weight of the pad after a 1 hour period. If it is less than 1.4 grams, that means not much urine has been leaked, and so you need not consider like it's a major incontinence problem. Okay, so in this corona time, I don't need to tell you about how well to use the sanitizers and washing of hands. Maybe your skin is more dry and cracked because of using of sanitizer. So it goes with this one also, okay? Because we are dealing with the urogenital system. Okay, next coming to, as I told you, the vaginal weights are also one of the means of strengthening the pelvic floor muscles. So if it is a weights in market, there are different kinds of weights which are available. And the moment you have to do while the weight is in, whenever you're using the weight inside the vagina, is the lift and the squeeze. So what are the uses of using the vaginal weights is, so prevent the uterine prolapse because we are strengthening the pelvic floor. Stress incontinence, pelvic floor strengthening again. So increasing the blood supply to the genitals. The same thing when we're using resistant weights to any of the muscles, the same thing we are using. But the thing is that we are not able to appreciate how well the contraction is there. So according to that, there are some EMG machines are also there. So when the vaginal weight is in, the electrical activity will be recorded on and it will be shown to the client. So in the further sessions, they can try to have apply more resistance and more squeeze and lift so that they're getting better day by day. Okay. So the weights, they range from 20 grams to 100 grams. Again, the progression is there. Don't go for the 100 grams in the first go. So it's always you have to go in the sequential fashion from the lower to the higher. Okay, if you want to know the material, it is silicone-free loop, which is the weight is made up of. And there will be a string part, which is attached to the weight. And the string part is always should be outside of the vagina. That means you are inserting the weight in a right manner. That is one of the indication you can know. So the weight will be inside. It can be like 20 grams. But the string which is provided to the weight, that should be well outside the vagina. That means the right insertion is there and you are performing the exercise with the weight in a right manner. Repetitions and sets are up to the patient's endurance level and the general need level. So usually you go for 3 sets, 10 repetitions in a day. You can have a lot of pictures in the Google. If you just click on like vaginal weights and all, you get a lot, all of them, and you can go through them also. Okay. And whenever we are speaking about the pelvic floor, so what are the functions of pelvic floor muscles? They have supportive function. You all know a lot of organs are there in the hammock of the pelvic floor. They are supporting them. Okay, bowel, bladder, uterus, and the vaginal canal. And sphincters are there, external and the internal sphincters. They help us to be continent, prevent the leaks. So there is another function like they stabilize a lot of structures, muscles, and a lot of structures which are bonded inside them. And so there is always a definite need to strengthen the pelvic floor muscles periodically and keep them in good condition. Okay. So whenever this approach from a physiotherapy point of view is concerned, so start from the history taking whenever you want to have any intervention for the pelvic floor in detail, just the pelvic floor. Okay. So pain, symptoms, what are the bowel and the bladder habits, diet, fluids, what are the fluids in a day the client is consuming, the job requirements of the client, whether they are lifting weights, it's a desk job, or they are sports persons, depending upon that. This is the first step, taking the general medical history. So now we dealt with the Kegel exercises, the vaginal goals, the means of strengthening. So these are the things, whenever it's pelvic floor, we should do Kegels. So I just covered the Kegels in the first part. So you can go for this examination and go for the treatment of the Kegels ideally. Okay. So whenever it comes to the examination, the medical examination part, I told you now, and the postural examination is very important. The skeletal alignment, it will change the length and tension relationships of the pelvic floor. So we feel like if there is some postural malalignment in the thoracic region, it's with the thorax we are dealing, but nothing. You all know how the postural alignment is there, right from the neck to the tailbone. So any malalignment anywhere will cause a distortion in the rest of the body. So you have to think about and analyze the structures, and any malalignment causes are there, try to rectify them, and in the form of either stretching, postural exercises, strengthening exercise, not strengthening as such, the postural exercises, stretching exercises, and the postural correction exercises. So, for example, its malalignment is due to the job, bad habits, standing habits, sitting habits, and whatever, like muscle imbalances, muscle weakness. Again, it's a very vast one. Muscle imbalances. What are the causes of the muscle imbalance? There are a lot of causes of the muscle imbalances and muscle weakness. So go into the evaluation of that one, and so you'll be at the step 3, that is the movement analysis. Activities, postures, and the movements that increase the symptoms. Ask the patient to do different movements, whatever you feel like in the thoracic region or the lumbar region, and pelvic movements, whatever they are, and see that what are the movements that are provoking more pain and increasing the symptoms. Okay, it's always better to do the movements not in a single take, to do them repeatedly, so you are able to pinpoint what are the really the provoking movements in the client. Okay, so if at all there are any movements which are directly causing the incontinence, your work is more easy. Okay, so your intervention will be, if the movements are causing the incontinence, teach the patient proper postural exercises, postural maintenance techniques, and lifting techniques. If in the job the lifting technique continuously is causing the problem, go for the ideal lifting technique. That's your ergonomic part also here. So we are covering a lot of parts like the pelvic physiotherapy in detail, the musculoskeletal part, the postural part, and the ergonomic part. Okay. Next comes the orthopedic assessment, a vast one. I think it's very less time and it's not our direct topic today. The spine, sacroiliac joint, which is very important. That's where the hell of problem is there. Hip joints, rib cage, the breathing patterns. So hip means what are the tight structures? If any of the structures are tight at the hip, try to evaluate them and try to have the relaxation techniques for them, stretching techniques for them, myofascial releases for them, and trigger point releases for them. Okay, tight back, the same thing. Shooter with the tools, all the tools in your kit. It can be like a myofascial release, same thing, stretches, relaxation exercises, or any other techniques where the tight muscles can be taken care of. Next is the pelvic floor assessment. If you just go into one specific topic of pelvic floor assessment, so there is external and the internal examination. So internal assessment, it is how you are able to know and judge the strength, length, and quality of pelvic floor, and also the trigger points and tension in the pelvic floor. This is such a topic like wherever if you are assessing, there is treatment attached to that. So if a good assessment is there, you are there at the treatment already. So there are scales. Scales also will deal like the perfect scale is there where you can assess the pelvic floor too, the power of the pelvic floor. Okay. And step 6 is patient education. So you did orthopedic assessment, you did pelvic assessment, internal and external, the tight structures, and you did even, if possible, perineometry, like having the perineometer with the vaginal electrodes and placing on the vaginal electrodes. So you're able to measure the power, you're able to measure the electrical activity on a physiotherapy point of view. So you have a lot of things assessed in the patient. So you are going for your intervention after a good patient education. So you have to explain to the patient what are your goals and how you are going forward with your treatment protocols. Okay. And you can use muscle energy techniques. You can use biofeedback techniques also. So whenever I told you about the internal physical exam, it's not only the structures, tight structures you are assessing. You can assess even the scars in the abdomen. Sometimes tightened scars, they pose some problems. For example, a C-section scar is there. So you can assess how well the mobility of the scar is there. That's also very important. And next one is, it is also important to assess, there are some scales out there to assess the scars if you want to have a detailed examination. It can be like modified Vancouver scale, Manchester scale. So you can all go through these scales also. Next is, as I told you, all the structures are connected. The thorax, your lumbar region, the sacral region. So have an assessment of the thoracic area, whether there is any hypomobility or hypermobility. If possible, the rib joint play can be done and thoracic rotations can be assessed. Okay. Now, so we are done with the assessment part. So we are assessing the tight structures. We are assessing the muscle power. We are assessing any of the structures like in the lower abdominal region, the scars, the scar tissue, or any of the other infections and all that will be mentioned in the medical part of the claim. So now you are at the biofeedback part. So biofeedback, it can be EMG biofeedback or it can be a simple biofeedback too. So biofeedback for the pelvic floor muscles, brain will feel that whenever you're involving your component of cognition also, right? Brain will feel, it will appreciate, and it is relatively slow range of movement. So you need to have some feedback for the patient. If you are moving your arm, the patient knows how well they are moving the arm and it's seen to the outside. But the contraction of the pelvic floor is not seen so easily. So it's always advisable that you use a biofeedback one for the patient. So they have more confidence in carrying through the exercise program. And There are certain devices by the biofeedback in the market and which are used in the pelvic floor clinics, like Periform, Neurotrack Simplex, Monitor Progress. For everything, the system is simple and one and the same. You will have a box which gives you auditory signals, you have the electrodes, and you have the probe which you have to use inside the vagina. So probe inside, and there will be some indicator stick also to know how well the probe is inserted and what is the power that the client is able to contract the muscles. It will be indicated on the scale. If she is able to contract to some extent, it will show like 4. To a lesser extent, it will show like 3 something. The scales are there, which they are company specific and all. You can go through once you get the basics, how to use the equipment. You can as well go for an ideal one, and everything will be clear cut, and you can use them to strengthen the pelvic floor muscles. So next one is, so as I told you, there will be sensor plates, there will be indicator that will help you to know about how well you are contracting the pelvic floor muscles. So I told you about the scale. So how to assess, for example, the client came for 2 sessions. Now you feel that she's doing better. She tells that she is able to hold the contraction. Initially, she was holding for 5 seconds, the squeeze and the contraction of the pelvic floor muscles. Now it moved on to like more than 5 seconds. So there is a scale which you can use like a parameter scale, which is known as perfect scale. P stands for the power modified. That's the power, how well they are able to do. And E is the endurance part. Usually we check up for up to 10 seconds. R is the number of repetitions they are able to make. And F is the fast contraction the client is able to maintain while maintaining the squeeze and the lift of the pelvic floor muscles. And each contraction is timed. Like 10 seconds, if the contraction is taking place for 2 seconds, they will record as 2 seconds. So this is a scale, very easy one, and you can use the scale and you can keep as a measure of how well the things are going on for your sake to show to the client too. And the rates of contractions can also be used for that. So I told you about biofeedback. So maybe I can give you a few brief introduction of what is biofeedback. It is a training technique that enables an individual to gain some element of voluntary control over muscular or autonomic nervous system functions using a device that produces auditory or visual stimuli. So you want to know how well you're controlling you're contracting your muscles, or how well you are able to coordinate this activity in the contraction of the muscles, and you want to have Zoom that's an auditory or the visual stimuli showing you all the information. Okay, next is I was telling, so the continent part, we deal with how to strengthen using the Kegel exercises, vaginal cones, the modern gadget, the biofeedback, and a lot of gadgets which are there. I just had a brief introduction about them. So whenever the pelvic pain is there, or whenever urinary incontinence with pelvic pain is there, you have to look into structures like whether the core is weak, so whether how well the pelvic girdle muscles are there. So when you have assessment of there, if the core has to be addressed, go for the strengthening, or any tight structures are there, go for the stretching techniques. Or as I told you, myofascial release technique, trigger point release technique, positional release technique, whatever suits for the patient, you can go ahead with that. Okay. So pelvic girdle muscles, like better you better know how the psoas major, glutes, iliopsoas, adductors, and abductors are there. So whether any weakness is there, mostly they are tight, most of the structures. So any tightness is there, so go for them accordingly, and you can fix the problem in the patient to some extent. Okay. To start with, that is very fancy also to have a Swiss ball in a physio clinic. So have a physio ball, and it's very easy to start with the exercises, the contraction part of the pelvic floor using a Swiss ball. So you can go over the like adductor strengthening, adductor stretching exercises, and strengthening of all the group of muscles, like whatever you feel like they are weak. So you can use the Swiss ball for the purpose to start with, and adductor strengthening and core strengthening. For any purpose, you know how to use the Swiss ball, you can go ahead with that. So what is the need for pelvic floor rehabilitation? So pelvic floor rehabilitation in general covers the components like pelvic floor strengthening, flexibility and strength assessments. I told you the group of muscles which need to be taken care of. Postural exercises, malalignment of posture. So fix right from the top to the bottom, like from the neck to the coccyx. Myofascial release techniques can be employed, relaxation techniques to start with. And nowadays, the breathing part is very important because how well the pattern breathing is there in our system, that's very important. So you can go for the diaphragmatic breathing. And you can have a home exercise program also on when the patient is coming for you for a few visits. You can incorporate all your some of the strategies the patient is able to do better in the clinic. You can just include them in the home exercise program too. And so there are advantages of biofeedback and the pelvic rehabilitation when it is going on. As I told you about the biofeedback, so it's both way helpful. Even it can be kept as a record for the patient as well as for the therapist. Okay. This part, next part we'll be dealing with is, we all know the pelvic floor. We feel like it is always weak, but there are certain circumstances or structures which lead to the negative tension in the pelvic floor. So whenever there is negative tension in the pelvic floor, so you need to go for relaxation techniques. That's very important. You need to shut off the negative stress which is there in the pelvic floor and go for the stretches. If any structure is tight, iliopsoas is tight, and if it is causing all the problem, if there is any problem in the obturator, so if it's the tightness, any trigger point are there, and any of the myofascial pain structures are there that are causing the pain, go for them and you have to address the accordingly. Okay. Next is so what are the symptoms when the pelvic floor is tight? Usually the client will be coming with the sudden urge to urinate, stress incontinence, a sense of being empty bladder. He will be having a sense that I did not empty my bladder to the full extent, and maybe constipation or coccyx pain. So depending upon that, you can come to one diagnosis that this is an element which is causing the problem in the pelvic floor. So try to fix it. So when it comes to the myofascial release of the painful points of this pelvic floor, better concentrate on the structures like stretching to the hip, gluteus, pelvic and abdominal muscles. And contract relax techniques, they work a lot with the prolonged stretch to relax the pelvic floor muscles. So sometimes when we were speaking about the malalignment, it's right from the neck to the tailbone. Sometimes the pain in the coccyx, coccydynia, it may predispose to some of the pain in the pelvic floor muscles, as most of the pelvic floor muscles, they are inserted into the tailbone. So you have to associate with all the problems the patient is having, analyze it, have an assessment. So if you are, for example, glutes, if you consider, they're attached to the tailbone too. So the patient may give a history like walking and running, put them stress, and it may cause incontinence or they're having discomfort. So go for the psoas stretch, gluteal stretch accordingly. Okay. So there is a procedure for the myofascial release. Whenever you're coming to the myofascial release and you want to release the structures, examination of the normal movement patterns is very important, and knowledge of this myofascial pain, to which structures it is referring to, and what are the structures it refers to. So you have to compare both the things and you can come to one conclusion and try to go ahead with that. And manual examination of the pelvic floor is also important. So you can carry on a couple of things and come to a conclusion what is causing the problem. So again, it's a team approach. If it is a myofascial pain also, the physiatrist, the person, he will be dealing with the part, the pelvic girdle and all, what is causing the pain. The urogenital specialist will be dealing any pathological structures, ruling out and give you a green signal like, go ahead with whatever the manual techniques you are dealing with, positional release techniques, the basic physiotherapy techniques. Okay, and rehabilitation. If any of the other rehabilitation person, you have to work hand in hand to have better results. So, for example, myofascial trigger points in the abdomen, hip, thigh, they may refer pain in the pelvic region. So it clearly shows that whenever patient is having some problem and he says that some abnormality, he's having some problem or some difficulty with the abdomen or some tightness if he feels in the hip, or if you are getting in your assessment, so you have to address them whenever you're treating with the pelvic region for the myofascial trigger points. Try to release the trigger points there which are causing the problem in the pelvic region. So to some extent, the pelvic pain may be that may be decreased in the client, and you can have good results too. So tight gluteus and piriformis. So consider whenever you are having examination, examine for the abdomen, hip, thigh muscles, gluteal muscles, piriformis. So whenever, for example, hypotonic muscles of levator, they give pain, referred pain in the abdomen. So when the patient is having referred pain in the abdomen, should have in the back of your mind. So let me go and see whether there is tightness in the levator muscle. So the approaches are like you should have basic knowledge whenever you are going through any of the approach. So so that we have a scientific way of dealing with the things. Okay. Whenever the patient gives a history example of I'm having an incomplete feeling of evacuation of bladder, it may be due to whenever there is puborectalis muscle is shortened, that gives a sensation. So it's an indication for you how well you can deal with the patient. So with all this talk which was going on, I don't know how well I was able to convey you or impart the knowledge, because it's a vast subject and every topic here covered, it can be a topic in itself too. But I just wanted to carry in the broad sense. Again, I'm my wish, and I think that if this can ignite in any of the students or other physios, like this is really a good specific field which is growing, advancement, research, and has scope in all the ways. So you can go ahead, do your own research. This one, and even a small clinic is a good one, where if at all you are attached with a gynecologist or a urogenital specialist, you can get a good good patient. I mean to say, handful of patients, so that you get experience. You can have you can apply your treatment protocols on them and get the results, and maybe you are able to share your results in the form of publications or any other thing, so that we people, physios all over the world, will come to know which works well for what. So that's how we have to enhance our knowledge and scope of physiotherapy. So comprehensive treatment, I told you, all the approaches are in a comprehensive way with all the fields. So comprehend with other people and try to have better treatment strategies. So I think I came to the end of this small webinar. So that's all from my side, and hope it's a bit interesting also. So thank you all.
Ma'am, thank you, ma'am. That was a great session from your side. We got a lot of information regarding this menopause and how we can relate this menopausal symptoms to our physiotherapy. What is the relevance between physiotherapy and menopause? Most of us, we don't know the clinical relevance about this field, especially. So we got some idea about this, ma'am. That was a very great session from your side. And I would like to ask the participants, if you have any doubts, you can keep that in the chat box so that I can ask ma'am on behalf of you. Participants, if you have any doubts, you can keep it in the chat box. I think one is having the doubts about this topic, as it is completely a new topic for all of us. Most of them,
Yeah.
uh, one of
Thank you, Archana. Yeah, it's a topic which is having a lot of scope, and it's an advanced topic. So, yeah.
Thank you from our college side also, ma'am. I would like to ask our principal ma'am to say a few words about this topic. Ma'am,
Yeah, Dr. Anu, it was indeed a very good topic and informative too. As Rameshwar said, though it's new, you could throw some light on the topic, and we could gain some knowledge and insights into it and how to manage the symptoms, especially menopause and post-menopause. That was really very nice. Thank you once again.
Thank you, Madhavi. Thank you for giving me an opportunity and meeting the people on this webinar occasion. Thank you very much.
Yeah, thank you for spending your time
Sure.
in spite of your busy schedule.
Thank you.